health promotion, health education, behavioral sciences, Ottawa Charter, implementing Ottawa Charter, and I think proceed model that you usually use for your thesis and your dissertation. Okay, next, Professor Stephen will give you his expertise in more detail. Okay, so before Professor Stephen deliver the lecture today, so I'd like to our respective dean to give a brief opening remark for our class today. This is actually the program of global classroom. The global classroom for master program of health promotion and actually for master program of health promotion, but the participant also come from undergraduate student, master student and also undergraduate student and online some doctoral program also join online. Okay, so please, Professor Budiono, as a dean to give a opening.
Thank you very much, Professor. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you very much, Prof. Stephen. You say Catholic to low brain. Sorry. From Belgium. Thank you very much for coming and joining in this lecturing. And today we are going to discuss about the Ottawa Charter implementation. And since 40 years ago, and according to WHO conference, I think, there are 5 pillars of WHO based on the Ottawa Charter, which helps the strategy public policy. And create supportive environment, strengthen community action, develop personal skill, and orient service. So there are 5 pillars, and under today, I think this Ottawa Charter is still relevant with our program, especially for the public health program, and this charter especially for health promotion, right? So I think it's very suitable for you to improve our knowledge about this charter and implementation this charter. I think WHO also give us this strategy for the implementation. One of them is advocate. Advocate is very important of us to support, to promote program of health in our community, to regulatory, for example, to our community too, and to private sector too. And also enable the strategy and make it. So we have to improve, I think, our community with the willing and skill, I think, to support themselves and know about their health, and they will promote health and so increase the status for health promotion in our community. I think today we have Prof. Stephen, and we are very lucky to soon that Prof. Stephen for giving the lecturing, and I hope you will active for discussing to take more related to Ottawa Charter, because it's very important. Thank you very much for the statement, and I hope also happy and enjoy this class. And because our university also give us the target for the one of this university global classroom development the global classroom system. Thank you very much again, Prof. Stephen, and terima kasih teman-teman sekalian. Silakan diskusi sesuai. Thank you very much. And Prof. Sarah also mentioned that this lecture also attended by other graduate and also this program with the online platform. So we conduct this lecture in the hybrid platform. Thank you very much. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Terima kasih Pak Dekan. Thank you very much. Apa sekalian tutup?
Oh,
Tadi kan dan orang ini satu ya.
Sudah tidak tidak masuk di enggak tadi bilangin
yang lain mungkin yang dosen PKIP ada di mana tadi? Oh ya, nanti baru salah ya. Saya PKIP Pak. Nah, help promotion lectures. Masih ya sebenarnya saya ingin Oke, terima kasih.
very much.
Okay, so we start Professor to deliver the lecture in the topic of health promotion. Since the Ottawa Charter, 40 years of training and capacity building within public health. So I think this is a good opportunity for us because the many experience in Ottawa Charter. Even in the afternoon, yeah, we have a meeting with the WHO talking about health Ottawa Charter, yeah, in the evening because they have a Ottawa, WHO, for European, or India, for European region, but we can join this afternoon, discuss with the WHO. Okay, time is yours, so you can explain your experience in Ottawa Charter, in basic possible in behavioral sciences, psychology, health promotion, and health education. Okay.
Thank you very much for the very nice introduction. It's a pleasure for me to be here. So not only a pleasure, it's a privilege to be here to talk to you today. The title of the lecture is indeed to talk about the Ottawa Charter, but mostly about what happened after the Ottawa Charter. So just to be sure, I was not at the Charter. Was not working in health promotion, but I have been working in health promotion since. So, my name is Stefan. I'm actually a trained psychologist, but I became promotion professional and researcher. I speak English. I unfortunately cannot speak Bahasa, so I hope that I will be easily understood. I know many people in Indonesia speak English very well, so I hope that this will help you to follow. Thank you. So I use the opportunity to tell you that I affiliated with the Université Catholique de Louvain as a professor, and I'm also working as a volunteer for the International Union for Health Promotion and Education, which is a professional organization of everybody working in health promotion. So the idea of the IOHP is to promote the professional development of health promotion and health promoters, and to make sure that people who work in health promotion are well trained, well on top, well aware of the progress and development in the field. And so I think this is also very fitting for the topic of today, because I will actually talk about capacity building and the place of health promotion within public health. So this is a public health faculty, health promotion is within public health. And so maybe not everybody knows very well the relationship between health promotion and public health. And so I think, or I hope to demonstrate that this has actually changed over the past 40 years, and that we have, as health promoters, taken a more prominent, stronger place within public health, and that we can continue. So for those of you, I think most of you who are planning a career or doing a career in health promotion, I hope this will be talking about you and about your future career as well. So that's my introduction. But let me start by the beginning. And the beginning is basically looking at the place of public health in the world. I think it is obvious that public health as we do it now is not the same as public health 100 years or 200 years ago when it was originally. So what we see in every country, in every part of the world, is that there's a changing burden of disease, that you have still infectious diseases and mother and child problems, but that there are more and more people living longer thanks to public health, but also more chronic conditions. So we see the rise of cancer, of cardiovascular diseases. We see the rise of some problems like diabetes. And as people grow older, the relative contribution and importance of the chronic conditions becomes more important. So, if you like, unwanted consequence of longer life expectancy is that more people will eventually develop chronic diseases that also need treatment. But that's not the only problem. We also have a very fast growing and changing society. And as a result of that, there's also more stress. So life is faster and it's more pressurized, and we try to avoid many more things. And as a result of that, we experience more stress and more mental health problems. Maybe I don't have the statistics for Indonesia, but if you look at Europe, it is now the case that mental health problems are the first reason for people to not be able to work. So it used to be back problems or muscular problems, but now it's mental health problems. And so you see that this is more taking space. And there's also a multi-morbidity, because very often people suffer from many diseases at one time. For example, people may have diabetes in combination with stress or depression. And so we see that this is also the case. And then in case of infectious diseases, we see a different pattern. I know that, for example, TB is still prevalent in Indonesia, but you also have HIV, which 50 years ago didn't exist. You have the COVID more recently. So you can have the more pandemic type infectious diseases, which are also to be looked at. And not to forget aspects like violence in society or injuries, also traffic accidents, also sports incidents and injuries also. So you see that because of the changing life patterns, different type of problems, health problems emerge. And the last one, I think, is definitely also related to pressure on the environment. So we have many more problems in terms of air pollution, in terms of waste that is also causing problems, aspects in the food chain. So the burden of disease has definitely changed over the last 50 years. With that, we also see something emerging, which may have been here before, but I think worldwide it is definitely changing. It's growing inequality. So you see that the gap between people who are well educated or less well educated, or between people who are rich and poor, is also widening. And this is something that that is increasing over the last decades. You see that the difference between the people who are very rich and very poor is increasing, but also the difference in health expectancies. So people who are rich, who are well educated, live long, suffer less from diseases, and so as a result of that, we see what we call health inequalities. We know that this is something that we have to pay attention to, because it's not fair that we do not benefit from the same healthcare. This is not only the financial aspect, it's also to do with psychology, it's also to do with access to care, with taking up care. So this is one of the aspects we need to look into. And then last but not least, and this is really more recently, 20 years or so, we see that there's a revolution in terms of the way in which information develops. I'm old enough to have experienced the time that you did not have internet to look up things when you had questions about it. So there was internet, but you didn't use it so often. Social media did not exist. Mobile phones, I saw coming. And so what we see is that there is, of course, an awful lot of development, also in Indonesia, mentioned, of access to health information online, which is, of course, very good, which helps you to get more information and to be informed. You don't have to go to the library, you can find it on your laptop or on your phone. Also, we have developments, technological developments like wearables. People with diabetes, for example, can have a sensor that shows them the blood sugar level or the cardiovascular, the blood pressure or the heart pulse can be monitored constantly. This can be connected to doctors' information. So in a way, we have a fantastic development in terms of information and informatics. But this has also other consequences. Not everybody has the same access to these things. People who are poorer cannot afford the access to the internet, and so they cannot benefit from these same developments. And so what we see is that with the increasing possibilities, we get unequal access to care and unequal use to care. So I think this is one of the points we really need to pay attention to. And it is also the point, by the way, that this afternoon, the session of the World Health Organization's symposium will be devoted to the access or the impact of digital means on health and health promotion in particular. There's also something else that's important. With the arrival of lots of health information online, we also see that it's become more difficult sometimes not to get to information. We have very easy access to information, but it becomes more difficult to make the difference between correct and incorrect information, useful or unuseful information or misleading information. So instead of finding it difficult to get information, it becomes more difficult to judge the information. So it's a different quality. So we need to do different things. We don't need to produce more information because there's actually too much information about health, but we have to help people to tell what is useful and what is not useful, which of course is a different task for health educators and health promoters as well. So I think we see that health has become marketed, has become a commercial good, And so I think we have to make sure that we do not make it too commercial, that we place health in the first place and not in commercial interest. So this is a bit of the context in which we live today, and this began 40 years ago. And so if you look at what we need to do to address these challenges, the new situation, I think we really have a good case of not only keeping to staying to cure people, to help people, but also to invest more in not only prevention, but also health promotion. And so, whereas most of our healthcare system in Europe, and I'm very sure also in Indonesia, our healthcare system is based on demand. When people get sick, they will seek help. So that's demand-led. So that is, I would say, the way in which health and healthcare and medicine has been developing for the past centuries, if not forever. But that needs to change. I think we need to go to change the attention not from what makes you treat health problems better to what produces health, but what makes somebody healthy and what are the determinants of health. So instead of more cure, we need not only cure and care, we also need to address what enables health. And Nadine just mentioned the fact that the World Health Organization in the Ottawa Charter mentioned enabling as an important driver for health. So enabling means that we make people more able to look after their own health. I'm sure you know this, and this is key for health promotion, but I think it's important to repeat. And so that means that the healthcare and also prevention needs to be changed, needed to be changed towards a different system that is not only curing, but also enabling people, healthy people and people without health, to look after their own health. And that was something that was highlighted 40 years ago when the Ottawa Charter for Health Promotion was basically launched. And health promotion is now celebrating its 40th anniversary, not necessarily today, but this year. And so when health promotion was launched, and I'm sure you know that, it was basically defined as the process of enabling people to increase control over the factors that determine their health. So the element of enabling the factors that produce them, this is very clearly in health promotion. So the Ottawa Charter was launched 40 years ago in Ottawa. And so 1986 seems like a long time ago. But so it was really a revolution, I think, in public health. As I mentioned, I was not there. I was too young to be there. I was still studying. I know of people who were participating there, and I can tell you that it was obviously a very stimulating and productive meeting in Ottawa, the Canadian capital. And so I think it was really the idea to change the approach to public health and focusing more on the new factors that were emerging and challenges that were emerging. So rather than this is a bit straight.
Yeah.
And on my screen, it's okay.
Yeah. Okay.
Okay. Yeah, this is better now. So we see that it was really a response to the needs that were then there, and some of them have changed in the meantime. But so the idea is to really empower people, to make people more able. So if you look at the history, health promotion is, of course, rooted in public health. It was a way to improve public health. So it's not something that is completely separate. Sometimes people think of public health and health promotion as separate. I don't think so. What exactly the relationship is between health promotion and public health? is still open for debate. Some people say it's a part of public health. Some people say it's a specialized practice area. Some people say it's one of the core functions. In a way, I don't think that's really important to find the best way to voice it. I think what is really important is to look at what defines public health and what defines health promotion within public health. And so what I think defines health promotion is the value system. It's the underlying values of health promotion, which are different from, let's say, mainstream public health or classical public health. And so if you look at public health as it has been developing over past centuries, it was a little bit paternalistic. It was with the best of intentions, but it was experts telling the people what they should do to stay healthy. So saying it's good to be vaccinated, so you should be vaccinated. It's when mothers or when women get pregnant and are preparing for their birth, for the birth of their child, they would say how to do that. So with the best of intentions, good advice were given, good looking after people as well. So that's perfectly fine. But so, of course, if you, as an expert, give advice to people, you take away a little bit of their control. And so the control was more with the experts than with the people themselves. Again, I'm not criticizing public health. I think enormous progress has been made through public health. I think actually public health has given more to health than medical science. But I think we should be aware of this idea. Now, if you look at the novelty of health promotion, it's that instead of this paternalistic attitude, it's much more focused on participation. So people should participate in the decisions about their health, should be empowered, so should be enabled to look after their own health, and should also be looking at equity. So health promotion is really trying to oppose the growing inequality in terms of health and access to health care and to the possibilities of leading a healthy life. There's no reason why somebody less well educated should not also be helped to lead a healthy life. I would almost say the opposite. So health inequalities has been a big concern in public health all over the place, but I think health promotion in particular pays attention to that. And so health promotion did not invent this as such. It's not something that is completely coming out of the brains of something. It is rooted in what we call the salutogenetic approaches that are also to be found in other areas of health. And it's also the idea of participation is also rooted in community psychology and community health. And if you go back to the beginning of the 20th century, also social medicine was also trying to achieve. So in a way, it's a re-entry of social medicine into public health, which I think is it's actually interesting to see from a historical perspective. So health promotion has its place in public health through values that are very important and very pronounced. And some people refer to health promotion as the new public health. I think of Ilona Bush, for example, one of the leading people in health promotion, one of the leading people also in the formulation of the Ottawa Charter. Ilona Bush is still very actively involved in health promotion, so still one of the thought leaders. And so I'm not sure if we really can say that health promotion is the new public health, but it has definitely changed public health, and it tries to change public health. So this is a little bit about the relationship between the two fields. And as I mentioned, I'm not sure if it is a part of it or a new focus of it, but I think it's especially important to look at how health promotion is introducing new aspects within public health. Now, this is not just me saying so. Um, I'm not sure if the my computer does not react normally. Health promotion, of course, has started at the Ottawa Charter, but since the Ottawa Charter, 40 years is a long time, so many things have changed and happened. And so if you look at the history of health promotion, there's been a number of follow-up conferences. So Ottawa was in 86, but then afterwards there have been conferences, WHO conferences in Adelaide, in Sundsvall in Sweden, in Jakarta, also in Mexico, and further on. So there's been every 3-4 years, there's been a conference organized by and with the World Health Organization. And the last ones actually have been online rather than in real contact. I think the last real conference in person was in Shanghai 10 years ago, and there I have participated. What we see is that there's been some fine-tuning and adaptation of health promotion to the new development in the world. The world has changed in 40 years. And if you look at that a bit more in detail, you see a number of steps that have been done. So here are the various conferences that you can list. The one in Rotorua, by the way, was not organized by the World Health Organization, but by the International Union for Health Promotion, but it's also in the list. Now, what have we seen in terms of change? In the beginning, so the first two conferences, well, the first one was basically the Ottawa Charter, which built on the Almaty Declaration of 78. So public health and health promotion was conceived in that concept. So the concept of health promotion was then built, but then the ones that came after in Adelaide and Sundsvall basically were looking at some of the principles and action areas of health promotion more in detail. More specifically, the idea of environment and health, so creating healthy environments, and also healthy public policies. So these were developed and more specialized or more detailed. So the first two were basically really linked to the Ottawa Charter action areas. But then afterwards, we saw that health promotion, which was originating mostly in, let's say, Western society, in very European, American, Canadian culture, was also taken to the world. And so the conferences in Jakarta, in Mexico, and in Thailand are not European or American or Canadian. And so we see that there, the fact of globalization became much more important. And so the challenges of a global economy and its impact on health became much more focused upon. And so that, I think, is important to look at, because the world has changed, has become more global, but so has health promotion, if you like. And then if you look further, in the last conferences, we see a very strong impact of the problems with the environment and with ecological challenges. We see and are increasingly aware of the fact that the health of the people and the health of the planet are very linked. And so in the Shanghai Declaration, but also in the Rotorua meeting and the Abu Dhabi statement, also at IUHPE conference, we see that we're now talking about planetary health and talking about the role of health promotion also to look after creating a very healthy environment ecologically. So I think we need to be aware of the fact that health promotion follows the challenges, builds on the challenges, and tries to address these challenges. And I think that's good, because otherwise I think we would not be looking at the right problems. You see no reference to ecology in the beginning, but I think the health and healthcare have changed. So this is something that I think is important to notice, that health promotion, as we see it today, is no longer the health promotion that we were talking about when the Ottawa Charter was launched. Now, what has happened to health promotion as a field of practice in those days? I think we can safely say that health promotion has really grown, has expanded enormously. And you're part of that. The fact that I'm here and that you're listening to me is a proof of that. Many more people are beginning to take up health promotion, are trained in health promotion and practice health promotion. So the workforce, if you like, the professionals who do health promotion are many more now than they used to be, than the few people who were interested 40 years ago. We see many more activities in health education, health promotion. We see also many more trainings. This is a master program in health promotion, so this is again an example of this. And we see that there's also institutions in the sense of health promoting institutes, health promoting foundations that also fund activities and so on. So organizationally, it has also become much stronger. So we now can easily say health promotion is much firmer, much stronger now than 40 years ago, which I hope is natural. What we also see is that health promotion has become much more a part of public health. The term for that would be mainstream. So health promotion has been included in public health. And so nowadays, I don't think there's many public health students or professionals who have never heard of health promotion or have no idea what health promotion is. They might not be as well informed as you are, but it's part of it. And so the fact that it's called new public health sometimes is a case in point. But what is more important is that health promotion is at the very least a part of public health training all over the world. And so I think this is something that's an achievement. There's, of course, other areas of public health that have not had the same success, if you like, to be integrated. And so what you see, I'd like to focus a bit more on that mainstreaming because I think it's terribly important. The effect of mainstreaming has been tremendous for health promotion. It's been very good for health promotion, if you will, because it enables to focus more on what health promotion really is and on the values of health promotion. So if health promotion is about enabling, then we see much more focus on the enablers of health than it used to be the case. So I think that's an advantage. Also, we can get the chance to show to the other public health specialists what we have achieved. So what are the things that health promotion has been able to change? For example, the fight against tobacco, which we haven't won yet, but we have made enormous progress. I think it's also interesting to look at the public health through a health promotion lens. So if you look at what a public health specialist or professional needs to have and be able to do, is increasingly also considered through health promotion. So we look at the quality of public health training, also looking at what health promotion can contribute. So in a way, again, this is quite an achievement and it creates opportunities for health promotion specialists. But there's also challenges. So there's never it's only good and never any bad or downsides. So I think the challenges for health promotion, or the challenges of the mainstreaming into public health, is that health promotion somehow lost a bit its visibility. So as health promotion, so it's become more part of public health, but it's become less visible within public health. So this is clear, maybe or maybe not very clear, but if you look at, for example, the identification of a health promotion unit within public health institutes or within training is not always so clear. And so the WHO, World Health Organization, is an example. There used to be a health promotion division within WHO, and now it's part of NCD prevention. So you see that there's more health promotion in NCD prevention, but it's no longer an organizational unit in its own side, in its own kind. So that's a little bit of a downside, and I think it means that sometimes it means that there's a talk about health promotion within public health, but it may not always translate with the same force as it could have because of the loss of visibility. So this is one of the things I think we should be aware of, and we should also look into when we look at this development since health promotion was launched. So if you want to address these effects, the negative effects, and also the positive effects, of course, we can welcome, but the negative effects, I think we need to continue to improve the information on health promotion and the research on health promotion as its own. So we have to keep on working on that. We look at the state of health, of course, but also at health behavior and health conditions. And we also should look at the effectiveness of intervention policies or interventions and policies. And so that's one thing. I think we should continue doing good research in health promotion, and of course at the university that has a health promotion program. That's part of it. That's an evidence. But what we should also do, I think, is to continue building the capacity, and I'll develop that in a moment, and also look at the competence of health promotion specialists is also keeping track. So these are three elements I will now develop it a little bit more if you're okay with that. I'm just using this moment to check if everybody's still here, if I'm not speaking too fast or too over the head. So please do mention it if for some reason there's a problem. But so if it's okay, I can just continue. Yeah. Okay. So let me look at capacity building. Building is actually one of the areas I'm very interested in health promotion, and I think it's one of the areas that health promotion has introduced also in public health. Now, what is capacity building? Very many people understand capacity building as building the workforce competence. So building the competences of people who work in health promotion to do their job well. For me, that's only part of the story, and I will talk about workforce competences also in a few moments, but I think we should look at health promotion capacities in a broader way, and I will explain why. So if you look at it in the narrow meaning, you're basically looking at competence rather than capacities. I think capacities, as used in public health and health promotion, refers to a broader concept. It's the capacities or the possibilities of a system, the characteristics of a system to solve problems, health problems in this case, and to respond to new problems. So if you see the world changing, and that's always increasingly rapid, you need to have, as a healthcare system and as a public health system, you need to be able to respond to them. If there's a new outbreak of a viral infection, you need to respond to that. If there's environmental disasters and public health consequences, you have to be able to respond to that. So in order to do that, you have to have the capacity, not just as an individual or as a workforce, but the whole system needs to be ready to do that. So that involves more than just the workforce. It also means leadership, it means development, it means research skills, it means the right organizations and so on. So it's quite a complex entity and concept, but I think it has its place and it's important. So it's a series of criteria, if you like, where you could say, okay, the healthcare system and the public healthcare system in Indonesia is capable of answering the challenges regarding public health and health promotion. So that would be the idea of capacity building. Capacity building has been discussed, has been raised in health promotion in particular. since just before the year 2000. So if you look at it, there's a bit of interest that has been raised there. One of the people that I have been inspired by is Penny Hall, who's from Australia. And so she looks at capacity building as as building sustainable skills, resources, and commitments held in settings so that they can answer the challenges, and not only once. It's not like answering a health promotion. This has been taken off, and so it looks at two things actually from a more make a program objective better and reach the objectives better, but you could also turn it around and you could say that in fact the project, for example, fighting TB or fighting COVID or diabetes in the population can be a way to also increase the system. So the learning of the system could be an additional objective in addition to the actual project objectives. I hope I'm not too unclear about this, but so that's the idea, that you can do many more things in one. That is a little bit the idea that was expressed by Ron Labalti. I think the connection is lost. So this is this is the way in which Ron Labalti has tried to address that. So I think my connection is slowly coming back. I hope. Yeah. So I'm apologizing for the lack of correspondence to what I'm seeing here and what you may be seeing from online or from the whole group here. So if you look at capacity, we have done some work in Europe with our team on identifying the dimensions of public health capacity, because there's been a few models introduced over the years, and so to get a little bit of a consensus, it's important to do a review. And so we did a review about 10 years, 20 years ago, and we saw, or we identified the main dimensions of capacity for public health. It means that you have good organizational structures, so health promoting institutes or public health institutes, that you have a good workforce, so the people who are trained to do health promotion and public health work, that you develop knowledge, that means producing knowledge, research, but also disseminating it, so good reporting of the research that you have, not only in top quality journals, but also in a way that can inform action, that you have the resources for it, so money and other logistics, that you partner up with other actors, because very often you're not alone. In public health, many organizations can collaborate, and partnership is an important dimension of capacity. And that you have leadership. Very often you see that when you have thought leaders, when you have champions, the field can progress much more. If I look at health promotion, for example, I've already mentioned Ilona Kiekbusch. I could also mention Tom Nutby, for example, names in health promotion that many people know. Well, these are leaders, thought leaders, and this can be the same at national level or even continental level. And so you can have that in public health, you can have that in health promotion, or in the combination of that. And it doesn't have to be one particular person, of course, but it's important that you have leadership, that some people can show the way, can enthuse other people as well. So these are dimensions of the public health capacity that we could look at, and this is what we can try to do when we want to see if a country or a region has enough capacity for public health promotion. We can try to map that. So you know what monitoring is of public health problems, but you can also try to monitor or map a capacity. So you see whether, for example, in Indonesia, if there are good quality champions, if the institutions are there, if there's good partnerships, and so on and so forth. So capacity mapping, I think, is important. It does not mention the performance. So it's not looking at whether health promotion is really successful in addressing, let's say, smoking or diet or overweight and so on. It looks at, do you have the conditions that allow you to undertake action that could be effective? So it's a different approach. It's looking at the conditions that will be necessary. So if you have better conditions, ideally you are better equipped to address the problems. So that's the idea of capacity mapping. And of course, if you want to something, it's good to have indicators so that you can measure that in some way or another, and possibly also compare between areas, between regions, between countries. And so this has been done in health promotion. One example of it is I mentioned the many conferences that health promotion has known since Ottawa. One of them was in Bangkok in 2005. And so as a preparation for that, there was a sort of capacity mapping exercise done by WHO. It hasn't actually been very much used after, but so the result of this is something like this. And so you see a number of the dimensions of capacity that were mapped out for the world by WHO. Unfortunately, this has not really been used much more afterwards in that sense, but I think it was really interesting to see at the time. This was only this is like 20 years ago, so it was only a little bit more than 20 years after Ottawa. But I think it was a little bit from the same perspective of trying to find out where do we stand, what is the capacity of health promotion at that moment. And so, although it hasn't been continued from WHO in that sense, it has been continued in other aspects, in other regions. And I was myself also involved or in charge of a capacity mapping exercise for health promotion and public health in the European Union. So the European Union is a group of 28 countries. At the time, it was not 28, it was only 25. But so the European Union, the European Commission, so the administration of the European Union, tasked us with the mapping of the capacities for public health and health promotion in order to address also inequalities. So it was a project, so we did that at one time. And so what we did, we used the capacity mapping model to identify and to score the existing capacities in all of the member states. So basically looking at France, Germany, Belgium, Finland, and so on, and mapping them. Now, we could, of course, go into the detail, but I think that would take us too far. But what I think is interesting is if you look at the relative capacity, so this is to be scored on a scale going from not developed to fully developed and functioning. So, and then you can see that there are differences on those different domains. You can see that knowledge development, for example, in most European countries was fairly well done. So we do good research on and knowledge development on health promotion. So it's a little bit under 5, but it's relatively good. And the same goes for leadership, for example, but financial resources scores much lower. And this is not probably surprising to you if you're working in public health. You know that public health is not the area of healthcare and health services that's most resourced. We get very little money comparatively to what we can mean for health, but that's the way it is, and that's the way most policies work. And what I think is also interesting is that also the workforce development is not so well organized, or was 15 years ago in the European Union. So although we have good knowledge and we have good leadership and even organizational structures, we don't seem to be training our people as well as we could, because the workforce development was judged to be not very effective. I have to say this is done, or the mapping was done through key informants. So this was basically asking a group of people who know about the structure in each country to fill that in and to use the indicators. So of course it's a perspective of specialists on what is the situation today. But I think although you can see this is subjective, on the other hand, I think there's a level of intersubjectivity, because collectively these people were very well aware of what the situation was. And I think by combining their scores and having consensus scores, I think we managed to systematize the mapping. And so this, I think, can be helpful to get an idea of which are the capacities that need further investing and which are not. You could take this a bit further and what we did in the report, but I'm just showing this as an example. You can then go a bit further and look, for example, at the difference between countries that have, let's say, a centralized or decentralized healthcare system or public health system. Within Europe, we have different countries, and not every country has the same care system or public health system. And so you see that there are differences in terms of which are the relatively better developed areas than in others. So again, I'm not going too much into the detail because that's very specific for Europe and it might not be interesting for you, but it shows you what you can do with that kind of mapping. You could look which areas are deserving better development, and also what are the factors that can lead to that. And so this is descriptive, but it can all raise hypotheses or ideas for further research. And so you can, of course, build that not only on the scores, but also on the comments. And so what are the strengths, what are the weaknesses? And so if I take the workforce development system following, and I think I'm losing connection again. Okay, here we are. So if you look at workforce capacity, so one of the dimensions, you can see, okay, what are the strengths that we have? So for example, a large public health workforce exists, professional associations exist, there's universities that teach public health and health promotion. But then for the weaknesses, you see that we don't often have the actual quantification. So how many people really work in public health promotion is not always well documented. And it's difficult to document because who is health promoting worker, for example. You see that although we have people working, that career opportunities and incentives are not always very clear. So people who work in health promotion, in public health, may not have the same opportunities for their career as people who work in the health sector. What are the strategies of development, for example, is also managing. You see that in the combination of the mapping with the documenting, that a bit more of a refined view on where we are in that particular domain of capacity. So that's the example of capacity development or mapping as a way to further develop. And so if I then go further in terms of the competences for the public health workforce, I think we should also keep in mind, and again, my slide's not following, I hope it will follow in a minute. I think we have to keep in mind a workforce is individuals, but it could also be organizations, and it could also be people who are doing health promotion in public health first half, but also people who do this as a side task. Let me be specific. This is a bit annoying that you cannot see what I'm saying. But so is the connection getting, I can't manage that. So I apologize for not being able to show what I'm talking about. So if you look at the workforce, you have what I would call the public health specialists, which are people who have been trained in public health and health promotion. Could also be policymakers who have the task to develop the policies for public health. Epidemiologists or people working within in the sector of public health. But then you have participants that are also contributing to public health, but are not necessarily doing this in the first place. If I think of a physician, a doctor can also do public health, can do health promotion, but it's not his or her first task. So in a way, I think this is a possibility of also training them and helping them to train, but they are of a different further field. You also have the ones who are also contributing, but who don't even think that they are contributing to health. Let's say policemen or firemen, they also have a role to play in public health and health promotion, but they don't necessarily do this even consciously with the idea to contribute to health. I don't know if I can make any change here because I'm not talking about something which develops, but so okay, here we go. So if you look at the workforce for health promotion, public health, I think we could ask ourselves then, given that there are so many different people within the workforce, can we actually consider health promotion a discipline, or is it something else? Is it really a profession or not? And I think this is worth a question. So in a way, if you talk about a discipline, you could health promotion is sometimes considered a discipline, but sometimes just a field of action or a movement. And so if it's a discipline or a profession, depends on the criteria to call something a discipline or a profession. For a discipline, you have to have a field of study that has its own knowledge domain, but also its own history, value base, traditions, ethical codes, preferred research methods, and so on. So the question is, does health promotion adhere to that? Is health promotion a discipline? And the same you could also say of the profession. Is a health promotion professional, a health promotion professional, or is the professional who does health promotion? It's not the same question. So to be called a profession, you have to have a recognized workforce. For example, if you say a nurse has to adhere to certain rules and so on, certain competencies, certain methods and so on. So if we apply this to health promotion, we can say, yeah, maybe health promotion is a discipline because we have our own values. I mentioned before that the values of health promotion are actually what defines health promotion. So yes, I think we can safely say that to that effect, yes, we do consider health promotion as a discipline. And we also have a methodology that is specific. If you look at evaluation, for example, evaluation in health promotion is different from evaluation in the medical science. We have other ways of doing it. We have other criteria of considering an evaluation, a good evaluation or not. In medical science, it's typically case control. In health promotion, we can't do that, but that's okay. So yes, to some extent, health promotion is a discipline, but some of the criteria are not fulfilled. We don't have a single paradigm. So if I go to a health promotion conference, it's not one particular paradigm. You see different paradigms coming up. Also, the theoretical foundations are coming actually from other disciplines. And I'm an example. I'm a psychologist and I'm doing health promotion. So is my discipline psychology or behavioral science, or is it health promotion, or both? And I think the same could be said for many other people. So the the basis of health promotion is at the same time psychology, sociology, communication science, education science, and so on. So it is multidisciplinary, if you like, and you can consider health promotion as multidisciplinary. But so it's not quite a single discipline. So health promotion is really what I would call transdisciplinary. So it is a combination. And that's at the same time good and at the same time a disadvantage, because many people who will do health promotion will not necessarily say, I am a health promotion specialist. I say so, but for many of my colleagues, I'm still a psychologist. And I think it's the same for you sometimes. So is health promotion a profession? We could say the same thing. And so yes, to some extent, health promotion is a profession because we train people to become health promotion specialists. There are university programs that exist, like here. There's also a professional association. I mentioned the International Union as a worldwide professional association, and often also at local or national level organizations exist. There's also even an accreditation system for health promotion training. So that means that, okay, we know what a good health promotion professional should be able to do and should be knowing to do. But at the same time, we do not have one distinctive institutional structure. So you may have different types or different structures for health promotion in different countries or even different parts of the world. The accreditation system is not everywhere the same, so that makes it also more difficult to share and to control. So if you as a health promotion professional after the finishing of your studies would go to Europe and say, I'm a health promoting specialist, then it is up to the country there to decide whether you meet the requirements to practice health promotion there, which, for example, is not the case for nursing or for dentistry. If you are a dentist trained here, you can practice in another country. So these are things that make the profession of health promotion also a bit more fuzzy, just like disciplinary status. So it also means that, in a way, anybody can just say, I'm a health promoter. So if you have an influencer online, they can say, I'm a health promoter, and they could even do damage to people because nobody will say, no, you cannot say you're a health promoter because you don't have the accreditation. And that, I think, is a piece. I think what we need to do for the future is to look at the strengthening of the disciplinary and professional status of health promotion specialists within public health. And so to that effect, I think we need to play out the fact that we are so many and that we are so diverse, which could look at as a disadvantage, but we can turn the disadvantage into an advantage. And so what I think is we should continue mainstreaming. And the mainstreaming means that we will be less visible, but that's okay. So if more people in pharmacy, in dentistry, in medicine know of and about health promotion and will recognize it as valuable, then I think we need to keep on doing that. And so that's fine. Those dentists, pharmacists, doctors will not be professional specialists in health promotion, but that's not a problem. They will recognize our value. And then in addition to that, I think we need to continue to build a workforce of true health promotion specialists like you, who will really know the essence and the nuts and bolts of what is health promotion, what is health promotion practice, what are the values, what are the different ways of working, and that really know what it takes to become a health promotion specialist, and could then continue to help the other actors to mainstream health promotion within their practice. So this is a little bit my take on it, and I think this is what we could continue doing. So to do that, I think we need to be very aware of what are the competences of health promotion specialists, because if we want to have people trained to do so and to be acting as thought leaders and active workforce, we need to know what they should be able and competent to do. And for that, I think we can go back to the competence systems that exist. And as health promotion is part of public health and integrated in public health, I think we could link this to the public health functions that exist. So there are lists of functions that are considered essential for public health workers. So again, the World Health Organization has worked on that. So the essential public health functions have been listed, have been developed, and are used all over the world. And so they exist also for health promotion, although that is sometimes a bit less known. The essential public health functions for public health. I'm not going to develop that here because I think probably you already know about that. And also, I'm not a public health worker, I'm a health promotion worker. And so this is basically a list of what a good public health specialist should be able to do, know, and manage. And so there's a list of 10 essential functions that are represented here. And so they serve as a guideline for training, for developing training programs, but also to accredit training programs. And so they are also implemented through organizations like international public health associations, including the European law. So this has been developed in collaboration with WHO and international associations for public health. And so if you zoom in, I'm from Europe, so I have a little bit more information about Europe. The Association of Schools for Public Health in the European region, the ASFER, has translated the 10 essential functions into 10 core competences, which they use to inform, guide the schools for public health within Europe. So all schools, in theory, all public health schools in Europe should be looking at these competences. So some of them refer to the content of what public health is and in what context. Some are focusing more on how a public health specialist relates to others, and some are more looking at what they should be able to do. So this is an example of this kind of core competences. So the content of it, I think, is interesting as such, but I think the meaning of it is very important. It means that you cannot say I'm a public health specialist unless you have all of these in your competency aspect. So this is for public health, and so this is also looked into and very much promoted. But what may be less well known is that we also have this for health promotion and health promoters. And I'm very proud to say that actually the health promotion was first with competency frameworks. So the fact that public health is now developing and promoting competency frameworks is actually thanks to health promotion. So it's not the other way around. So public health is following health promotion and not the other way around. And so the competency framework for health promotion has been developed through two systems. So one is the Society for Publication in the US. So, and on the other hand, the IO. Into existing compact public health one, so you need health promotion knowledge, the ethical values that come with it, and then the competences of advocating, mediating, enabling that are key to the Ottawa Charter. And then with that comes also the challenge, the possibilities and skills to implement, to plan, to implement, to evaluate, and to assess the needs. So the work of a health promoting specialist should be guided by these skills. So that translates into a number of competency domains. So these things listed here. And so the idea is that if this system would be implemented worldwide, then you would say, okay, somebody trained in health promotion in Indonesia could also go to Europe or to the US or to Australia and say, okay, these are the things I master because this is something that I have learned in my training. And I've been tested on that, I've been examined for that. So it's been developed by IUHPE through a project that took place a bit more than 20 years ago and has been updated since. And so what this framework, which is called CompHP, Competencies for Health Promotion, it has been forwarded and taken forward by the IUHPE. There's a global working group that works on that. And so the idea is to frame that also in terms of using it for accreditation. And so we have been developing with the IUHPE an accreditation system that can be applied to trade, to basically university training in health promotion, so that if you say my university wants to establish a health promotion program, what should my students know at the end of the ride? Then you can use this as a framework, and you can also use it to test the quality of your training against them. And then at the same time, you could also apply it to individuals, but that is of course a bit more complicated because then you need a system that people need to have an accreditation. Most countries don't have a need for individual accreditation, certainly not for health promotion. So I think the value of that or the interest in that might be less high, whereas most institutions, universities do need accreditation for their programs. So I think that's probably more the way forward. So the accreditation system implemented by the International Union does both. So there's a system where you can apply for accreditation as a training or as an individual, and it's voluntary. It's not imposed, it's voluntary. So those of you who might want to do that can apply for that. And of course, it's designed to be flexible because we know that the situation is different in different parts of the world and in different countries. So this is more or less where I would like to arrive at. So I think we've come a long way from Ottawa. I think we've come by putting up some principles and action areas. We've seen a whole development to take the developing world or the developments in the world as a reference point. So we've constantly adjusted. I think we've also been much more aware of the ecological and other challenges and of globalization. We've seen mainstreaming of health promotion in public health, with its consequences, both good and less good. And as a result of that, I think we've come at the stage where, as health promotion specialists, we can ask ourselves the question, are we functioning in a system that has enough capacity in terms of the full meaning of the word? And within that capacity, are we as individuals, as professionals, sufficiently equipped and trained to do a good job? And I think we have the capacity, the competency frameworks to judge that, to even go towards accreditation. And with that, I think we can manifest ourselves and continue manifesting ourselves as specialists in a field that is increasingly recognized as a quasi-discipline or a transdisciplinary field and as a profession. So I think this is the way we can not only work towards being recognized, but also to create the future of health promotion within public health. My last slide is not showing, but I think it should be showing shortly. And I think to quote somebody very wise, is the best way to face the future is to create your own future. And if we create our own capacity and competency frameworks, I think we can shape the future of health promotion. So thank you for listening, and I would like to offer the time now for questions and have a discussion. Thank you.
Yeah. It's very interesting. topic. So you talking about, first is about, public health routine. It's come from old paradigm based on my biomedical concept, right? And then that's why you say benevolent partner paternalism. Yeah, right. So and then maybe we can change to focusing more in empowerment, in participation, and equity, and also health literacy. Is it related to salutogenetics concept? Yeah. So maybe you can explain more about that. And then you move to the capacity buildings in health promotion. Yeah, capacity building, is it a system to solve new problems and response to unfamiliar situation to improve the capacity of the people uh, to able to think creatively in terms of health and the problem in health, and also inform leadership, service development teams, and workforce. And also you do the, maybe explain about the capacity mapping, including community capacity mapping, and strength and weakness of public health and health promotion. And the last one is the future of health promotion. I think that's the content of the lecture of Professor Stephen van den Broek. So please, if you have any question, please feel free to ask and discuss. Or maybe, Yadi, you can check in online. There's any question for Professor Stephen?
No, no.
No? Okay, from this class first. Is there any question? Okay. Rahmatullah. Yeah.
With permission of dear professors, I should say Assalamu alaikum wa rahmatullahi wa barakatuh. I should introduce myself. My name is Rahmatullah Nazari. I am originally from Afghanistan. It's about 8 months that I'm here. Right now I'm studying Bahasa Indonesia. So I'm not officially in health promotion faculty, maybe next semester. This is not a question, it's like knowing about the opinion or idea of Professor Stephen. Professor Stephen, let me start with an example. There is a well-known Professor Harari, graduated from Oxford University, and he is lecturer in Jerusalem University in Israel. He stated that in the future, it's possible that AI could enslave us as we enslave the animals, and also it could even lead to extinct of us. So my question is that even like AI, in every aspect of our life. So my question is, what's your idea? What's your opinion that AI could, how they could affect, or what they affect, they could possess on health promotion, the opportunity and also the threat. So even there is an example, or there is a competition contest between AI and specialist doctor. So in this sense, even AI succeeded. So AI performed very well. Yeah. So just I would know your opinion about it.
Thank you. It's an example. Thank you for the question. It's an example of a challenge that we are facing. So like ecological danger, like globalization, like commercialization, the very rapid development of information, and now not only social media, but also AI. Of course, it's an event. It's something that develops in the world and that everybody has to factor in, not only in the health sector, of course, also in the economy, in every field of the world. So your question goes beyond health, but also has an impact on health and on health promotion.
Health promotion in particular, I think, because of course, although sometimes people will consult the internet or the AI to get a medical advice, I think if you look at the use that is made of the AI, it is more for health questions when people are not necessarily ill. So it goes more, I think there's data on that. So I think about 90% of the questions that are asked about health are not about health problems people have, because then they will still go to see their doctor. But are about, for example, should I do this or should I do that? Can I use this kind of supplement? Or can I, is it enough if I do that number of exercise and so on and so forth? I think of course, I don't have a crystal ball. I don't know what AI will mean, but I think it is at the same time interesting, at the same time also a threat. Not only because of the possible replacement of specialists. I don't think AI can actually replace professionals, because AI can only reproduce what is known. AI does not construe new thoughts or new ideas. So AI will never or cannot really replace. But of course, that is something people will have to realize and learn how to realize. And so, if I may, for me, that's an important reason to pay attention to digital health literacy. So health literacy is the capacity, the competence people have to find information, but that's not a problem, but to understand and critically evaluate. So health literacy has been understood and is being researched and has shifted a little bit, because it used to be more difficult to find information about health when you needed it or to understand it. But now I think it becomes much more important to know which information that I find is valuable, is complete, is correct. And then I think people should realize that AI will never be as good in providing answers than somebody who really knows what you're talking about. I'm not saying there's nothing good about AI in terms of health advice, but it's basically an algorithm. So it builds on information that's available somewhere. There's an awful lot of information on health available, and AI does not make the distinction between valuable or not valuable, complete or not complete. So even when the systems learn, they only reproduce, and so I think that could not be the future. So we will have to rely on the fact that, well, hopefully there will be more regulation on where AI can be used or not, but that's more like a policy decision. And I think also people will have to understand, for health and for other aspects of life, politics, for example, or economic decisions, that it's not always true what AI produces. And maybe you should do the exercise sometime to ask a question that you very well know the answer of, and ask AI and see how wrong they can be. You can also start to hallucinate. I've done that a few times, and you can even get into a discussion with AI and say, no, you're wrong, and then they will come back and say, yes, sorry, you're right, I am wrong. So I think for me, it's a phenomenon, but I think it's only a good reason to really focus and strengthen people's digital health literacy, and especially critical health literacy.
Is there any other question? We still have 8 minutes more. Okay. Yeah. Ada pertanyaan lagi? Ada yang mau tanya? Pak Bagus, Prof. Bagus, Bu Rati, many health promotion lecture. If you want to ask, actually, I would like to ask you could explain about salutary genetics concept. If you want to focusing more in empowerment, equity, participation, and improving health literacy for the people. So
Juga kali teman
Maybe you can explain that.
yang buat teori.
Yeah, thank you. So
Really,
salutogenesis is I think, a way of thinking about health that has been around for a while, which goes back to the idea that health is not something, health is something that can be considered more in a positive way. So it's rather than looking at the absence of health, we look at what is the positive side of health. And so salutogenesis is looking at what are the factors that enable health, that drive health, that are basing the people's feeling about health. So I think it's much more participatory and recognizing the way in which many people spontaneously think of health. I think we have, so in health promotion, salutogenesis is a source of inspiration. And it's there is within health promotion, I would almost say, a school of thought that is salutogenesis. I don't know to what extent it's part of the training here too, but so salutogenesis for me is a source of inspiration. It's not a set of practices, it's more a principle-based approach that looks at health in terms of a positive aspect. So whereas most of our healthcare is actually looking at absence of health, what we call healthcare is actually sickness care or ill healthcare. Whereas if you look at salutogenesis, you look at what are the factors that make people feel good, make people healthy. And when we ask somebody, how are you? And people, or if you wish somebody good health, we mean more than we wish you to not get ill. We mean people to feel good and to be able to be in control of their health, and that's central to salutogenesis. So to some extent, like I mentioned before, it actually goes back to social medicine of before, but then in a less paternalistic way. It looks more at what people can do themselves to look after them. I hope that explains it.
Online, okay. There's a question from chair.
No,
You're very sorry, and can you can you show the question?
raise hand langsung sebelum.
Okay. Okay, I give a time for Theodorisa, Yani, Beth, you can unmute your,
Yes, hello.
yeah, okay. Okay, you can ask directly to Professor Stephen, please.
Okay, first of all, I'm so sorry that I cannot turn my camera because of the network issues caused by a power outage in my area. Okay, good morning, Professor Stephen. My name is Theodorisa Riani Bate, but you may call me Riani. I'm an undergraduate public health student majoring in health promotion. As a student who is still very concerned and interested about current health promotion issues, I honestly feel a little bit confused and worried about the futures of health promotion itself. From the discussions about specialized versus mainstream health promotions, I understand that health promotion is expected to become more integrated across different sectors and disciplines. However, at the same time, I also see concerns about the unclear professional's identity, weak institutional structures, and limited professional recognition for health promotion practitioners, even though there's an organization such as the International Union for Health Promotions and Educations have already developed competencies and standard accreditation system like COMHP. In addition, when looking at the current global political situations, such as geopolitical conflicts, economic instability, shifting government priorities, and the growing influence of industries and political interests of health policies, I become even more concerned about the actual positions of health promotion in the future. So I would like to ask, since the Ottawa Charter itself emphasizes empowerment, supportive environment, health public policies, strengthening workforce, governance, and health promotions, why does its implementation globally still faces problems such as weak political commitment, the dominance of economic and industrial interests, creative-oriented health system, and unclear professional legitimacy? Even with the competency standard an international accreditation system such as IUP and COMHP? And why does health promotion still seems to struggle with professional recognition and a clear career identity compared to other health promotion itself? Do you think these international accreditation systems are strong enough to improve the legitimacy, sustainability, and future career security of health promotion as a professional globally, especially as health promotions become more mainstream rather than specialist based? Thank you.
Yes, that's a long and a complicated question. But if I can, right, yeah. So thank you for that question. I think it actually illustrates the importance of the wider view on capacities and not only at competences, because indeed, if we want to make health promotion more noticed and more powerful, I think we should not only invest, we should of course invest also in the development of the workforce along the competence systems that I talked about. I think this is absolutely important that we continue working there and implement. But at the same time, I think we should also look at the other capacity elements. And you mentioned political systems and political support. I think that's one of the capacity dimensions that I think we should also look at. It's the political environment and the recognition and the support you get from government. And in order to do so, I think we need to advocate. And so advocating for health promotion is part of the competency systems. So a good health promoter should also be able to advocate and work towards the government. But at the same time, of course, this could also be shared by others, including other professionals, other organizations, and also international organizations. And in that regard, I think, again, the World Health Organization is an important actor and will continue to argue for the importance of health promotion. And so this afternoon, there will be also a session on that that is broadcast, that one can attend, to celebrate also 40 years after Ottawa. But I think also the IUHPE is trying to achieve that as well. IUHPE does not have the strength or the power, if you like, or the political clout of WHO, but can nevertheless also help people to pull their energy and their convincing matters together and to identify ways in which good practices are showcased and can also be shared so that people can follow the examples of successful efforts to advocate. All the domains of capacity building should be put in practice if we want to achieve and if we want to continue strengthening health promotion and health promotion practice. I hope that answers your question. He's muted again.
Can you hear?
Hello. Okay. Thank you, Professor, for the answering.
Thank you.
Okay, so I'm finished. Thank you very much for your lecture. It's very essential lecture for today. So actually, we still need more. I mean, like the community capacity. Maybe yes, I think. But in the first time, I bisa. Oke, thank you very much. Terima kasih banyak atas kehadirannya hari ini. Semoga bisa bermanfaat buat kuliah Anda, terutama Ottawa Charter, Health Promotion juga tadi ya, and Community Capacity Mapping. Oke, sekali lagi terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi.
Waalaikumsalam.
Thank you.
Thanking loh.
Kirim aku ya.